Welcome everybody to today's meeting of the Norfolk and Waveney CCG. I'm Dr. Anoop Desi and I will be chairing the meeting today. This meeting is being broadcast live and is available to watch on the CCG's website whilst we are in public session. Please note that the meeting is also being recorded. This recording will be made available after the meeting on our CCG website. There is an opportunity for members of the public watching the meeting to ask questions about any items on the agenda or to ask for clarification if they're uncertain of anything that is discussed in the meeting. This can be done by sending an email with your question to nwccg.communications@nhs.net and that email we will make available on the website. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case the response will be prepared in writing and sent to the requester within 7 days of the meeting, and the answer will also be set out on the CCG website. The governing body meeting is a meeting of the CCG which is held in public, but it's not a public meeting. So accordingly, any questions not relating to the agenda items will be answered and displayed on the website, but will not be read out during the meeting. Okay, so let's make a start. Hopefully you've got your agenda items and agenda pack in front of you. And hopefully you're using the diligence software, which you've had training in. So have we got any apologies for the meeting today?
No, Chair. No,
thank you. Okay, and item 3 is declarations of interest. So again, a reminder that any interest that you have, any potential conflict of interest, must be kept on the register of members' interests. So make sure that's up to date. And either declare to me now if there are any agenda items to which you may be or seem to be conflicted, and also if during the meeting there is an item where you think that there may be a conflict, let me know at the time. So are there any items where members feel that there may be a conflict? Okay, thank you. So item 4 is to approve the minutes of the last meeting, which was held in July, and in September, so 29th of September. And I'll take that as a pack in terms of accuracy. Are there any matters on the minutes of the last meeting in September that people want to correct for accuracy? No? Okay, and are there any matters arising from that meeting which we're not covering on the agenda today? No. Okay, I don't see any hands, so we'll approve those minutes as they were presented to you. Item 5 is the action log, and I need to report to you that I've taken a couple of actions as chair since our last meeting, which are in your agenda pack, and they were both in relation to medicines. So we approved the psoriasis treatment pathway and some formulations for medicines, specialist medicines related to rheumatology, which are on the agenda pack. I think that was to meet the deadline that's required when recommendations are made and to avoid delays in patient care. So I've taken those actions as chair, and I think they'll be reported on later when Michael does his section on further recommendations to be approved. The other actions are on the action log, which I'm just getting at. So does anybody want to talk me through? So the governance handbook has been deferred or paused, is that right, Karen, still?
That's been deferred until the new year. There is one further update on the action log, and that is the following action around the minutes from July, and Claire has now sent me that information, so those minutes have been updated. So I think that action can also be closed.
So that can be closed as well. Great. And the finance plan is being part of the finance report today. So I guess nothing to add to that, John.
No, nothing to add to that. We'll cover that under the finance report.
Okay, great. Thank you.
So I think that action can be closed, therefore.
So we can close that action as well.
Yes.
Okay, great. Thank you. So let's move to item 6 then, which is Melanie's Chief Officer's report.
Thank you, Chair, and good afternoon, everyone. My report covers the main activities that the CCG and team have undertaken since the governing body last met. And it's just a report for information. I wanted to just highlight a few key areas in the report, and then I'm very happy to take questions afterwards. I wanted to start by giving a very, very heartfelt thanks to all of my colleagues across the whole health and care system. Wanted to mention, of course, all our staff within the CCG who are working tirelessly and incredibly flexibly to support the Norfolk and Waveney population as the pandemic continues. And also all of the staff in the health and care system, but particularly those colleagues in general practice who are making really quite extraordinary efforts to keep people safe. And as we'll hear later on in the agenda, have a very, very important role to take in the rollout of the COVID vaccination programme. And this comes on the back of the outstanding work that general practice are doing to vaccinate very high numbers of the population, much higher than previous years. And indeed is the case in all of our hospitals and community and mental health trusts as well. We'll hear about that later in the presentation, but really, really wonderful to hear about those high flu vaccination rates. Everyone, of course, is having to adapt how they work, whether it's working from home virtually or looking after people who may have a positive COVID infection, whilst at the same time in general practice or in other health and care settings, keep people safe who do not have that. And this is requiring immense flexibility and innovation and use of digital technology. And we continue to see how well people are adapting to these changes. The NHS, of course, is in a level 4 incident, and that's been a change since the governing body last met. That's a level 4 incident according to our emergency planning and preparedness framework, which we're going to have later on the agenda, just in terms of our annual review of that. But that does give the NHS a very clear focus on management of the pandemic, but also management of winter during this period as well, which is an additional extreme pressure that we didn't have during the first wave of the pandemic. Kath will give us a presentation later about the COVID vaccination programme, which the CCG and health and care system has been planning for some considerable time. And whilst our plans are very well advanced, there is still lots of guidance coming down from the centre. As you'll hear on the news, even announcements are coming out on a daily basis that we're adapting to, but it's clearly a very positive indication that will be a significant focus and is a significant focus for both myself personally and the whole executive team and organisation. Great many people are involved in that. I wanted to just also briefly touch on 3 final points on the report, which, as we know, the pandemic has exposed really deep inequalities in health and the wider society, certainly. And so it's right that we, as an organisation and as a team, reflect on what we need to do more of to support people from more disadvantaged backgrounds, especially during this second wave, when many of the conditions that were apparent in the first wave have indeed worsened for so many people and so many livelihoods. So there is a great deal of work going on around health inequalities, and I'm very pleased that this is in partnership with district councils and voluntary sector as we look to keep a more localised community focus on addressing people's needs. I wanted to mention as well, I'm very pleased that we have applied to join a reciprocal mentoring programme, which is a national programme to support and give more opportunity for leaders from diverse backgrounds. We wait to see whether we have been successful with the national bid that we've made, but certainly I feel it's a programme that we would commit to whether we are successful or not, to support more of a diverse talent within the CCG. And then finally, again, I wanted to touch on the green social prescribing bid that the CCG made to NHS England. And it was a wonderful experience developing the bid, meeting many new to us, but it's very well established environmental groups and green groups. I think the Norfolk Green Group was one of the partners that we worked with to develop our bid, really to encourage people to make use of the wonderful open spaces we have in Norfolk to improve their well-being. Sadly, there were very few groups that were successful, and unfortunately we weren't one of the successful bidders for the green social prescribing bid, but nevertheless I'm very pleased that we now have links that I hope we will be able to sustain with many community groups to have a positive impact on the health and well-being of the Norfolk and Waveney population. So very happy to take any questions or comments, Chair, on the report.
Thank you. Thanks very much, Melanie. So are there any questions or comments for Melanie's report? No? Okay, thanks very much for that. Let's move that then to the main items. So items 7 and 8 are focusing on COVID-19, which obviously is very much preoccupying the work of the CCG. So first, we're going to have a presentation from John Webster outlining the COVID-19 and winter pressures. So over to you, John. Are you there, John? Are you on mute perhaps, or?
Is that any different, Chair? Can you hear me now?
Yeah, I can hear you now. Yeah, I can hear you now.
I don't know what button I pressed, but I'm back, so thank you. Apologies for that. Yeah, just looking at the COVID incidents on this slide across the whole of Norfolk and Waveney, but making comparison with the east of England and England as a whole. Since the start of the pandemic, the incidence per 100,000 has been lower for Norfolk and Waveney than both England and the east of England. But you'll see from this table, it is a rising trend across the system. Highest rates in Great Yarmouth and Waveney currently, with the rate actually doubling within the last 14 days. We've also seen sharp increases in South Norfolk and Broadland. Some of this has been driven by outbreaks you'll be familiar with in those areas within food processing plants. But there's a very definite transmission in the community, and we're obviously as a whole system very alert to that. This is not just around isolated outbreaks in businesses, but across the board. Interestingly, I think North Norfolk is showing very low rates compared to the rest of Norfolk and Waveney, and indeed nationally, with 61 per 100,000 population with a positive COVID diagnosis within the last 7 days. If you could just move to the next slide, please. Thank you. I think in terms of this one, looking at COVID patients or positive patients in hospital, There is an error actually on the small table there on the bottom right-hand corner of this slide. That should read the 31st of October, not the 31st of November. But basically, point being that you'll see the trend within that graph, and there's an increase since the second national lockdown was advised of an increase of 96 up to 139 COVID patients in hospital, and the breakdown in the table there across the three hospitals. The most significant increase just recently would be within the Norfolk and Norwich. Similar position around ICU patients, which have increased from 4 to 12 over the same period. Just like to point out, this data is prior to the recommencement of the Norfolk and Norwich Hospital as a surge centre, regional surge centre. And made the point, biggest increases in patients within the Norfolk and Norwich. And if you could go to the next slide, please. This table, or a couple of tables here, draws the distinction between the number of patients admitted with COVID-19 and the number of asymptomatic inpatients being diagnosed after admission. And you can see there across the timeframes of that table, in all time periods, the number of asymptomatic inpatients being diagnosed with COVID-19 is higher than the number of patients being admitted with confirmed COVID-19. I'll come on and say a bit about that in context of testing on a later slide. But clearly this is the hidden problem, the asymptomatic patients, and we're seeing a trend emerge within our data that shows more asymptomatic patients in hospital than we've previously known about. The next slide, please, covers the deaths in hospital, and as you might expect, it's following a similar trend to the number of COVID positive patients that we're seeing increasing across Norfolk and Waveney, as I showed in the first slide. To date, there have been 456 people with COVID-19 that have died in our hospitals between July and September, that is. In the past 6 weeks, we've seen 30 people that have died. So again, an increasing trend, but one which the lockdown is designed to try and help alleviate. The next slide, please, takes us to testing, and the government has made a number of recent announcements around its plans to expand the testing regime. This slide includes some examples there. So in primary care, there's a national portal that's been established for practices to access swabs, primarily for testing practice staff and their household members. So seeing a real push around increasing for our primary care teams. Biggest such announcement just recently has been around testing of asymptomatic NHS staff. Arrangements are being established now to put in place twice weekly testing for all patient-facing staff. And the reason behind this is around prevention of the virus being transmitted within hospitals and other healthcare settings, and supporting staff's availability to care for all of our patients. And that would include an impact around our elective care recovery work and how we start seeing our elective care programme increase in future. The James Paget is one of 34 trusts nationally that has been running a pilot of what is called lateral flow testing. And the Norfolk and Norwich Hospital and QEH will have also received the technology. Actually, I've had that confirmed this afternoon to me. So they are now in place to start providing lateral flow testing as well. The big focus is really around the rapid turnaround of results. Excuse me, this is not an area that requires a lab test. There are cartridges, as I understand it, clinical colleagues will correct me wrong, that have a reagent that allow the test to be rapidly turned around in less than an hour. There's another suite of tests which are slightly more complex and require a degree of further or additional training around rapid diagnostic tests with the DNA nudge test and the Samba test, which have a 90-minute turnaround. So you'll see there's a real emphasis here, not only around increasing the capacity for testing, but also importantly to make sure that we can keep the flow of patients within the hospital. It's really around rapid turnaround of results. If you could go to the next slide for me, please. I think we're now moving into a couple of slides on flu vaccinations, and we're currently ahead of our trajectories for vaccinating the over 65s. You'll see on there that by the end of November, we're hoping to be up around 75%, and there's good progress being made there, as you can see from the trend line on the graph that's shown there. By the 10th of November, we'd vaccinated 68% of the over 65s, which amounts to 173,000 or thereabouts of the population. Compared to this time last year, we've vaccinated 68 against the 61% of the over 65s at this point of the year. So some really amazing work being done by the teams to really push the flu vaccination, and really important that's done as well ahead of accessing the COVID vaccinations, which Kath will come on to describe shortly. In terms of the under 65s, those at clinical risk or groups of those at clinical risk, there's a national target to vaccinate 75% of that group by mid-December, and you can see that on the far right-hand side in terms of the trajectory. Again, we're currently ahead of the trajectory for testing under 65s at clinical risk. By the 10th of November, we'd already achieved 63%, which is around 77,000 people. Could you just drop down a slide, please? I'm sorry, I've moved on to the under 65s and you're still on the over 65. Sorry, I hadn't seen it on your screen. Compared to this time last year, it's 63% against 50% at this point of the year. If you do next slide, if you wouldn't mind, please. So this gives a comparison of our frontline healthcare workers across the different organisations that have been vaccinated. There's an ambition to vaccinate 100% of frontline staff. We're making good progress towards that, and I think there's a couple of noteworthy organisations there. The Norfolk and Norwich are currently at 74% of staff vaccinated. There's been some really good progress as well within the Ambulance Service Trust this year, who are currently at 72% in terms of vaccine uptake. Into the 60s, there's a couple of areas that we're following up with, as you'll see within the table, where rates are slightly lower than we'd like them to be. But overall, really good progress with 2/3 of frontline staff already vaccinated. I think this is the final slide from me, thank you, which is just to talk a little bit about some of the winter pressures, and just as a backdrop to this slide, I think we're seeing a general picture, obviously, of increasing demand, particularly at our acute hospitals, with levels returning to pre-pandemic levels. And we've just taken there is a paper here with this from the associated paper under this item, just 4 quick areas of focus for us around mitigating pressures. The first is the implementing Think 111 First programme. This is a national programme designed to encourage patients, members of the public, to contact 111 first if they have an urgent care need. This has been a very big programme of work for us across the system. A number of us presented to an assurance meeting last week with NHS England and Improvement. We're still waiting to hear the outcome of that assurance process, but the presentations given were very favourably received. There's been an awful lot of work gone into this from our staff, and we're really hoping that this will be a major feature in terms of managing some of the demand in the system going forward. There's a real focus as the hospitals are getting busier around effective ambulance handover times, and this is really important in terms of releasing ambulances to get back on the road and not being delayed at hospitals. And so as a principle, we're continuing with the principle of drop and go, which allows ambulances to offload quickly when they receive another Category 1 call, so they can leave the hospital immediately to collect the next patient. Some of that is facilitated through creating appropriate cohorting areas within the hospital, and we are supported by the ambulance trust with staff within the EDs of our 3 acute hospitals with hospital liaison officers. They work in support of the ED teams to allow rapid turnover of the ambulances where possible. There's a big focus at the moment for us around discharges, and there's a number of things going on here, not least around securing or commissioning additional discharge capacity. We're also holding senior review meetings, which are being led by Kath Byford, our chief nurse, with each of our hospitals to really have a focus on improving discharge pathways and processes. And finally, enhanced streaming at the Norfolk and Norwich. This has been primary care streaming effectively has been really successfully operated at the Norfolk and Norwich in recent months, and we're looking at opportunities for how we can extend that model to the other 2 acutes in the system, and incorporate that within the Think 111 First work that we're hoping we get the green light for shortly. I think that was the last one from me, Chair, so I'll pause there for any comments or questions. Thank you.
Great. Thanks for that, John, for that. I mean, you've covered a lot in your slides. Thank you for going through it in a timely way. And I think the governing body members should not underestimate the amount of work that goes on. And this is really the focus of what both our providers and the CCG have been looking at throughout the last month. You've covered various aspects. I think we perhaps ought to spend a little bit of time on each one because we've got a little bit of time for discussion. And I'm going to ask the first question, actually, if I may. You covered the COVID-19 cases, and the timelines were for confirmed cases up to the 9th of November, which kind of predates the second lockdown. And I know that nationally we get kind of like daily reports, and nationally the reporting has been. On Friday, they were saying that it looked like things were flattening. And on yesterday's report, the Prime Minister said that actually it does look like numbers are coming down in terms of new cases and admissions. Is that the case locally? Have we got local figures that kind of show that things have kind of are reducing in terms of new COVID cases and admissions locally?
So I'm happy to start with that, Chair. I know I had a conversation earlier with both Mark and Jossie who might wish to add to this, because there are some issues around how the data is presented, which will get clear as it goes through, and I'll let Jossie explain that because she's been working with PHE around it. I've looked at some data slightly more up to date, Chair, and it's a mixed picture. We are seeing it coming down in some areas, but we're still seeing some increases in others. An example would be in Kings Lynn and West Norfolk, where you'll see from this a reduction from 133 to 130 was on the slide that I presented over that 2-week period. We'd actually seen a slight increase again by the end of last week in Kings Lynn and West Norfolk. And it's part of my point really, as we've been picking up with Louise Smith, our Director of Public Health. We shouldn't become complacent around outbreaks either, or focus too much on outbreaks. Yes, they're important and they're a huge source of work to try and turn those areas around. But this is very much a virus that is still out there in the community. It's still being passed on, and actually that's reflective of some of the data that we're seeing. So while we've seen some coming down, we're seeing some other areas increasing again as well. Overall, though, our levels are significantly lower than the east of England and England as a whole for Norfolk and Waveney. Jossie, I don't know whether you wanted to say something about the data, because it's a particular issue around students returning as well that's masks some of the data here.
Yeah, thank you, John. So that's completely correct. So PHE has updated the way it records the location of people who test positive for COVID. So it now prioritises the addresses given at the point of testing over the details registered on a patient's summary care record. And that is in the main because when all the students went back to uni, their first port of call was not to go and register with a GP. And so what was happening was when students were coming out and testing positive, the positive case was assigned to the GP practice where they were based, so that skewed the figures. The one thing I would say is that reconciliation is still taking place, but the change has been made retrospectively to all tests carried out from the 1st of September. So what that means is the data that we're currently looking at, whilst not markedly out, might be slightly out. So we're going to have to just wait for that to come through. The other thing to say is we always have to reconcile our data to the PHE line list, which is why the data always has a 5-day lag against it. So we do have very up-to-date data as of yesterday, but it must be reconciled with what Public Health England are collating. So it's much more appropriate that we wait to their timeline where and consequently there's normally a 5-day lag. Thank you, Chair.
Thank you. Thanks for that. Anybody? Any other questions on the COVID numbers yet? So I've got a few hands up. So Tracy and then Kath.
Hello, thank you, Noob. So I'm Tracy Williams. I'm one of the clinically elected members on the governing body. So my question is in respect of the lateral flow testing that currently we're understanding it's mainly for acute hospital trust, but just wondering any thoughts, or have we heard that there might be opportunities that it's extended to community mental health settings and primary care settings? So that question from me, thank you.
And I mean, is it worth just taking a couple of questions and then they can answer together maybe? So I saw Kath, your hand up, and then Rob as well. I think I saw your hand.
Do you mean Kathy? Yeah, yes.
Yes.
Thanks. So I'm Kathy Branson. I'm the registered nurse on the governing body. My question was about care homes, and I just wondered if we had any information on both the testing process and also disease prevalence within care homes, please.
Okay, great. And Rob, did you want to ask your question, and then we can try and answer them together?
Yes, thank you, Chair. I'm Rob Bennett. I'm a lay member on the Clinical Commissioning Group. Firstly, on the flu vaccinations, John, it's very pleasing to see those numbers coming through in the way in which they are, particularly compared with last year. But I think it's also good to hear that you said you'd be following up in a couple of areas on the staff vaccination rates, because looking at the numbers, there are a couple of outliers there. So I was very pleased to hear you say that. And on the discharge, improving discharge capacity, again, I think that's a very important area for us to get right, and will make a big contribution. It might be something that Kath wants to comment on as well, but I'm just wondering what the working relationship with social services is at the moment, because again, that's a key working relationship to success for us. Thank you.
Okay, thanks, Rob. Shall we take those first two first? Because I think we might have some discussion around some of the other things that were discussed in the presentation later in terms of flu rates and discharge capacity. But so Tracy asked about the lateral flow testing and the situation with care homes. Who can answer those questions?
I'm happy to kick off. I think Kath might well want to join this. I mean, in terms of the guidance received so far, and the piloting work that's been going on with those 34 hospitals nationally, you're absolutely right, Tracy. This is an acute focused beginning to this testing. There's nothing by way of formal guidance suggesting that extension yet, unless you know differently to that, Kath, but I'm not sure it has been notified to us yet. It's testing it within the acute settings, but I would guess, Tracy, in the way that it's developed over the course of the pandemic, that we will see it moving to community settings too, and I think that's very much in line with the increased capacity that the government are looking for. In terms of the second one about care homes, I think I probably will defer to Kath on this one, if that's okay, Kath.
Sorry, I'm navigating through Diligent as well as this system. So in terms of the care home prevalence, what we need to get an up-to-date percentage of care homes that have been affected since the beginning of wave 1. What we have seen is certainly into wave 2, the bigger area of outbreak relates more to the care home workforce as opposed to the residents, although that is starting to go up a bit more. In relation, so there was at one point a 1 to 4 rate in relation to residents to staff being affected with COVID, and it's about 1 to 2 now. So we are keeping a close eye on that and keeping a huge amount of support available, working in partnership with the local authority to support all of the care providers, not just care homes, but also domiciliary care providers and other sources of care such as daycare and supported living. We can provide the most up-to-date data in relation to care home outbreaks, and I'm sure I can get that and share that later in the meeting if that would be helpful. On mute, Anoop.
Tracy or Kathy, did you want to come back on those answers? No? Okay.
Sorry, I was unmuting. I think it would be helpful to have further information in due course, because I think, as Kath said, there's a complex picture outside of the hospital. So I think we need to be assured that we're keeping a watching brief. Thank you.
Okay, great. So are there any other questions on the COVID numbers before we move on to some of the other things that John talked about? Doris, is that your hand up?
It was, I think it's more a comment actually on the North Norfolk figures, because although they're low, they've actually doubled. And I just noticed that the Duncan, the MP for North Norfolk, is campaigning quite hard for Norfolk to be in a low area. But I just worry there might be complacency in terms of the numbers are low, but they're not really in the community, which is what you've been saying already.
Okay, no, thank you for that comment. That's absolutely right. I noticed that as well, that they double, as you say. Any other comments on the COVID? Okay.
Sorry, it's Jocelyn. Can I just make a couple of observations? So,
yeah.
so again, just in terms of the North Norfolk figures, can we just be started on the reconciliation piece I said about the PHE data, because some of the figures are gonna look markedly different because of that PHE piece. But you're also absolutely right, we can't be complacent, because we now know that there is no one single outbreak that we can kind of pin the numbers down to. There is community transmission out there. So North Norfolk looks low, and that's fabulous, and let's keep going with that. But at the same time, you know, there is a level of prevalence out there in the community. The only other thing I wanted to say was just about the care home figures, and I'm so sorry because my WebEx keeps kicking me out, so I'm not sure if Kath referred to this or not. But we do know that across all of the care home settings in Norfolk, we've only had something like 60% of our care homes have had a situation or an outbreak. Now that's compared to colleagues over the border, where those percentages have been higher. So good news, you know, I mean, it's gone quite well. And the other thing is, you know, as of yesterday, for our care providers, not just care homes, for our care providers, we've currently got 59 outbreaks, which again, it might sound a lot, but if you look at that across our entire care provider number, that's not bad at all, Chair. Thank you.
Okay, thank you. And just a reminder for people to mute their microphones if they're not speaking. Rob asked a question about the flu rates. Can we, yeah, Kath, do you want to address that? And also, can I just ask you as well to give us an update on where we are with the second numbers of flu vaccinations that we're doing for the 50 to 65s, which have been released or been announced in the last few days? Yeah,
absolutely. So in terms of the flu vaccination for the frontline workers, the paper sets out the performance for each of the providers. What I will say is that now data is 2 weeks old, and there has been significant progress since the data that's been able to be shared. I can honestly say that the providers are really pushing this. This is an area of utmost importance for them. We've got some outstanding providers within Norfolk and Waveney, and in fact, in the top 6 providers within the east of England, 4 of them are from within the Norfolk and Waveney patch. What we do know is that we have one or two providers that the vaccination rates are lower than we would want them to be, but we have got a strategic flu cell, and we are providing support between the providers to enable some learning of success to be shared across the system. The trust, I think, which needs the greatest level of support and focus is the Mental Health Trust, NSFT, but they are really very committed to improving their flu vaccination rates over and above what's reported and what they did last year. In terms of the 50 to 64, it was announced that this is a group of people who will be able to access a free flu vaccine, and it's anticipated that this will be from December onwards. The providers, both community pharmacists and primary care, are now gearing up for the extension or the expansion of the programme, and people will be contacted by their practices if they're entitled to a free flu vaccination. In terms of the discharge capacity, Rob mentioned as well, the community capacity and discharge cell remains very active within Norfolk and Waveney. This is the cell that was initiated at the beginning of our wave 1 of the COVID outbreak, and this is a system-wide group comprising of all of the providers within Norfolk and Waveney and both local authorities, in which we work together as a system to look for ways to both enhance capacity in the community, but also improving the discharge pathway for patients to be able to exit the hospital in a timely and safe manner. And as a success of COVID, this group, I think, is one of those successes where we have engendered a whole system approach, and it's where actually sometimes some difficult conversations can happen, but in a very constructive and supportive way. The specific point about the working relationships with the local authority, again, I think this is an area of strength where we've seen even greater working relationships with our local authority partners, to the extent where we have full involvement from both the local authorities at chief executive meeting level, which happens twice a week. There's an integrated commissioning group, which John and his colleague from North County Council co-chair. They're fully engaged in the community capacity and discharge group, and we meet daily in relation to the work that we're doing together in partnership. And whilst there's always opportunity to improve the way in which we work as a system, we're doing it together as opposed to in an antagonistic and confrontational way. So I actually feel very positive about the work that we're doing together with the local authority to not just create more capacity in the community, both in care settings and to support people at home, but the way in which we're doing that is in a very integrated and supportive way.
Okay, thank you. Rob, do you want to come back on that at all?
Only to say, Chair, thanks very much indeed, Kath. That all sounds really, really good, and I think underlines the point that you made earlier, Chair, about all of this hard work that's going on in the background, and it's good to know about that. Thank you.
Okay, thank you. Hilary, you've got your hand up.
Hi, Hilary. I'm a GP on the governing body. So my question really is about the flu campaign. So as Melanie and Kath have mentioned already, the practices in our area have been working really very hard to move forward, pushing lots of numbers through in terms of patients to get people vaccinated as quickly as possible, and they've got really well established call systems for getting the high risk groups and different age groups into the practices to get their vaccinations. What's caused some difficulty recently has been communications that have been sent out centrally in the practice's name. So they're going out to patients with the practice name on them, so it looks like they've come from the practice, but they haven't. They've come centrally and are giving patients different advice about how to make appointments. And this is causing a lot of calls to practices. Some of these patients have already had their vaccines and therefore are a bit confused as to why they've then subsequently got a letter, and some people are in groups where the vaccines aren't currently available in sufficient numbers for them to get vaccinated immediately. So I wondered whether there was any opportunity to influence where these communications are coming from in order to reduce some of the workload that is falling onto practices, and also some of the concern that is happening for our patients who are getting communications from different sources.
Great. Kath, do you want to respond to that?
Thank you. I think it's a really important point that Hilary makes about, again, reinforcing the enormous amount of work that's happening in relation to the delivery of the flu programme. And despite all of the hard work, sometimes things can get in the way of that, such as Hilary described, communications coming out from a more central route. We continue to go back to region and share the concerns that are being made with us from practices, because it's really very legitimate. And we take that back through the cells that the regional team chair and lead, learning experiences from what's happening in other parts of the east of England. And we try and keep practices as informed as possible with very comprehensive, frequently asked questions that go out every week from the primary care team. Not wishing to sort of pass the buck, but we will continue to try and push back and advise region of the challenges of the consequences of their actions, and we'll just try our best to keep maintaining that momentum of communication, but continue to apologise on behalf of the wider system when sometimes it doesn't quite go to plan.
Okay, Hilary, did you want to come back on that?
No, just to say thank you, and it's really reassuring to know if that message is being sent up the line, so to speak. Thank you.
Yeah, I think that's a really important point around communication and being consistent messaging for patients. I mean, I did want to sort of reflect on the new cohort of patients, the 60 to 64 group, which is being offered. You know, it's a large group of patients who are being offered a free vaccine this year, who are not used to being offered or thinking about being vaccinated for flu. And I know practices are gearing up, ordering large amounts of vaccines to vaccinate these patients well before the COVID vaccination comes in place. And I do wonder whether the CCG should get involved in some messaging locally, making people aware that actually they will be contacted and make themselves available to have that vaccine when it's offered to them. Because I think I just get a sense that it's going to be quite a hard sell for these groups of individuals who don't normally qualify or think about getting vaccinated to now be offered a flu vaccine when the focus is on COVID. But I think just reinforcing the importance of being protected for flu, particularly in the climate where they're at risk of getting COVID as well, is really important. And I think the CCG probably does have a role in communicating that locally. Yeah, Melanie, did you want to come in?
Yeah, thanks, Anoop, and also thanks to Hilary for your question too. I mean, I absolutely do agree that the CCG will continue to communicate with the public, because of course we have already been communicating with the public. If you remember at the start of the flu vaccination programme, when the new cohort, the 50 to 64s, were first announced, I think there was a flurry of requests to practices from people who were keen to come forward, and so we communicated back to them as best we could through the general public as well, that not yet, wait for this. But I think there are a number of misunderstandings as well that would be important to think about some careful communications on, because I think I have heard a number of people express to me or asked me what's the link between the COVID vaccination and the flu vaccination, and of course there is no link whatsoever. It just so happens that there are two very important programmes happening at the same time, but for different reasons we would encourage people to come forward for both. So I think that's something we will take away and think about what more we can do, because it's important. We want to get the numbers up, we want to support the population, we also want to take pressure off practices where we possibly can do. So thank you, Anu.
Great, thank you. So are there any other questions on John's presentation that people want to make before we move on to the next item? No? Okay, great, thank you. And thanks, John, for presenting that.
Thank you, Chair.
So let's move on to item 8, and Kath is going to give us an update on the planning for the COVID-19 vaccination programme.
Thank you. As everybody had sight of the paper, I was just going to whiz through and pull some key points out to share, if that's okay. So, in essence, the COVID mass vaccination programme, I don't think anyone can turn on the news without seeing something about this every day. And there are two, what I see as two areas of focus with regard to the mass vaccination, one being our population, and the other being our health and care workforce. This is a nationally driven programme with expected delivery at a sub-regional and a local level, and working in partnership as a system, but very directed by the regional team at the behest of the national team. In terms of who would be vaccinated,
Kath, sorry to interrupt you, but did you want your slides on there or not? Because they're not on. I don't think they're being presented at the moment.
If people would find the paper helpful to put on the screen, I'd be very happy for that to happen.
Yeah, are we able to do that? Are we able to do that so that people watching can see the slides as you go through?
Hi, Chair. There are slides for this. It's a paper, but we can get those put up now.
Thank you. I'll carry on if that's okay whilst
Thank
Jane
you.
puts them up. Lovely. So the paper sets out that there are 11 cohorts identified for people across the population to be vaccinated, with the main cohorts of focus for the immediate term being cohorts 1 to 2 and cohorts 1 to 10, sorry. So cohorts 1 to 2 are more vulnerable population, those who live in care home settings, the staff that look after them, they fall into cohort 1, and cohort 2 includes health and social care workforce, along with our population that are over the age of 80. And they break down into two groups, those that are housebound and those that are mobile and able to leave their own homes or their care settings. Cohorts 1 to 10, the aim is for that to commence in December and to be completed by the end of February. And then cohort 11 is expected to commence in February and be completed by the end of April. There are 4 plans for delivery of the programme. So in no particular order, we have the roving model, which will support patients who are housebound and live in care settings, and there'll be PCN models, so there will be hubs in each of the PCN footprint or in most of the PCNs, which will initially support over 80s that are mobile and health and social care staff. Then moving on as well, we will have mass vaccination centres and of course the large provider workforce who will be responsible for vaccinating their own staff. The logistics, as I'm sure you can imagine, is taking a huge amount of focus. Some of the logistics is being directed and delivered at a national level, some at a regional and some at a local level. And we have got people from within the CCG and the wider system working really hard on supporting that logistical challenge. Workforce is an area of immediate focus. And we need to think about the workforce that are needed in particular to support the mass vaccination sites, the roving team and the PCN hubs. And legislative changes are taking place to enable a wider group of staff to be able to undertake vaccinations. And Anna Morgan, our STP Director of Workforce, is coordinating with her team, and areas of sources of staff include bring back staff, the reservist, actually advertising for additional staff, and also redeployment from within existing health and social care settings as well. Communications to the public in relation to the mass vaccination programme is very much being nationally determined in terms of content and timescales, but as a local system we will continue to support local communications to our population so that it translates the national message into one for our local residents. And finally, from a governance perspective, We have a weekly strategic cell with delivery groups sitting underneath, including workforce, estates, etc. A detailed plan in progress, and I'd like to give credit to the staff across the system that are working entirely on focusing on the delivery of this programme because of the pace and intensity that's needed. We have the agility and the focus within our workforce to be able to respond to the requirements to deliver this programme. As I said earlier on, there are regional meetings and regional groups in order for us to get direction and support at a regional level where required. So I'll stop there, Chair, and happy to take any questions, but just to say that there are aspects of this programme which remain confidential.
Thank you very much, Kath, for that. And I mean, I think, as you said earlier, that logistically, this is probably one of the biggest programmes that the NHS has been asked to deliver in its history, really. And new issues are emerging almost by the day, and as have been reported nationally with vaccines, etc. So, any questions or comments people want to kick off with? Yeah, Tracy.
Hello, Kath. Hello, everybody. So I just want to ask, really, in respect of the priority groups. I am part of the flu cell, so I do know some of the kind of the processing and some of the planning in respect of the COVID vaccinations, because we've amalgamated those cells together. But I think with the priority groups, because there's so many and how we're starting, I think it is a very confusing message for the public. So I think what we can do locally to kind of, get those comms out and reach those groups is extremely important. And knowing clearly with our population that we do have a very elderly, more so population in Norfolk and Waveney. The other aspect is in respect of some of those more underserved groups, so those groups we find difficult to reach, and some of our approaches towards that. I think we've probably had some learning from some of the flu vaccinations that we've done and how we've approached those groups that we can continue with that with the COVID vaccinations as well, because I think there might be quite a lot of people that are quite anxious and nervous about this vaccination as well. So it's kind of those hurdles to get over too.
Thank you. Yes, in terms of the communications to our population, we've been told that people will be contacted through the national system with a booking system that's in development, but we will need to recognise how we support our population who may not find that approach as easy to navigate through. In terms of the underserved groups, I think it's a really important point, Tracy, really well made. And actually, this is an area where we have thought about this before actually we were being directed to look at this. And we have a group which, and you're involved in that, Tracy, in providing great leadership in that area, about how we can look to really make sure that the underserved groups don't slip through the net, aren't missed out, and therefore aren't adversely affected. So I'm talking about the homeless and rough sleeping population, for example, but also other areas where other groups that may be underserved typically, that is really important. So just to assure the governing body that we have got people really enthusiastic about this, including, as I say, particularly driven and led by Tracy, to stand out and do a really good job in this area, so that we don't focus on those people that are normally easily contacted and are more responsive, and which results then in, of course, further inequalities within our the outcomes for our population.
Thank you. I think that's a really important point about accessing those patients who are hard to reach, and actually, in some sense, prioritising them, because we know there's going to be delays in getting them to get vaccinated. And I think underlying perhaps what Tracy was saying also is some pragmatism and flexibility. Will there be some flexibility if couples, for example, have 1 or 2 years difference between them? Will we really not want to vaccinate people because they're 2 years younger than the current cohort being done? So I would hope there would be some flexibility in that as the programme progresses. Hilary.
Can I ask, there's been in the news recently, for example, that certain airlines will not allow you to fly unless you've had a vaccination, unless you have some form of certification to prove that. If other industries or organisations follow suit, How do you think that will play into the vaccination programme as it emerges? Because at the moment it looks quite clear it's done very much on age groups, but if there are other factors that come in, for example, that relate to people's employment or other aspects of life, how do you think that will play in?
That's a really important point, Hilary, and I'm not sure that that's necessarily been raised within the regional groups that we participate in, but it is most definitely something that I will ensure is taken back. What I will say is that it won't be long until we get to the end of April, which is when we will have expected all of the cohorts to have been vaccinated. But I think it's a really important point about maybe how people may be discriminated against in relation to choices or ability or availability of vaccine, depending on where they live or what they do or what their beliefs are. So I'll take that point back, Hilary, because it may well be that that's a national decision to manage that sort of behaviour.
Okay, Melanie, did you want to come in on that?
Yeah, thank you. I mean, yeah, it's all over the news today, isn't it, Hilary? And I think we're going to be seeing this on a daily basis, something new and potentially that will grab everyone's interest on a daily basis. I think it's really important for us to stay focused on what we understand today and what we can do. And national guidance is just emerging very rapidly because we're operating at such a pace with all of this. So issues like that, which it was touched on in the Prime Minister's press conference last night about whether vaccination would be required or mandatory, and of course that's not how this country operates. That's not the same across other countries, but you can see, we're having to operate at such speed that guidance and policy is being developed very, very rapidly. And I think there is a risk for us as an organisation and as a system that we need to be absolutely mindful of the public mood music. I think that's really important, and knowing what's on the news and what's emerging. And that there is a risk that we speculate too much on things that are outside of our control. And just with the huge task we have ahead of us, I think it's really important that we are acknowledging what's emerging in public consciousness and discussions, but stay really focused so that we can deliver what we currently know, which is going to be a huge task in itself. But thank you for the question.
You're on mute, Anu.
Yeah, thanks, Melanie. That's a point well made. Any other questions or comments on the COVID vaccination plans as they are at the moment? No. Okay, good. We're doing okay for time, which is good. Okay. Well, let's move on to item 9 then, which is to receive an update on the work that we're doing with public and patient engagement with our Mark, who's our lead for public and patient involvement. So Mark, over to you.
Says this is by way of follow-up to report on the work that's been undertaken under the framework that governing body members will remember we signed off in May during the first part of the pandemic. Just to update you on what's been going on now, we're in the second lockdown. I'm very grateful to Rebecca Champion and Oliver Cruikshank, the two engagement managers who've been leading on this work, who've prepared this paper. And you'll see they've summarised in there the work that they've been undertaking with individuals and communities, both to shape, test and disseminate messages, but also to involve them and engage them in commissioning projects. And the work falls under 4 main heads. Engagement in relation to COVID-19 itself, where they've been working with voluntary community and enterprises, the patch, as well as organisations that support such as what is mentioned in the paper, Lowestoft Rising for the Waveney area. They've also been working with Tracy Williams, who's our lead for health inequalities on the governing body, to develop the groups that they work with further and in furtherance of the agenda that she's pursuing there. The second area is in relation to the COVID Protect service, and you'll see they've had feedback from some 252 people. There's a summary in the paper there. The majority of people who completed the survey found the service to have been very or quite useful, common themes of valuing the feeling of support and getting advice. And those who'd requested clinical support, the majority of those who replied in that area said that they were also satisfied with received. And then the third area is in relation to Think 111 First, which John Webster mentioned earlier. There they've been working with partners ahead of the national launch of that on the 1st of December. And then the fourth area is the recommended summary plan for emergency care and treatment respect. An engagement survey has been undertaken. Period. Some focus groups are planned for bearing in mind the particular sensitivity around resuscitation preferences during the pandemic. The report's going to be shared with the focus groups and its plans in the new year developed further to develop an awareness campaign for the respect agenda. So I'm just asking really for the governing body, please, Chair, to note that report and comment and discuss any particular points within it.
Great, thanks very much, Mark, for that. And I think patient and public involvement is actually a core part of our remit in terms of our commissioning, that we need to involve the public and patients at all stages of our commissioning cycle, including in planning services. So I think, thank you for that update. And particularly in the current context, I think it's very difficult to communicate because people aren't allowed to meet in normal ways. But I think hopefully we can demonstrate through your report that we are in the current, even despite the limitations of communication presented by COVID-19, that we are using all the available resources to reach out to the public and patients. Any comments or questions for Mark or others on that report? Rob.
Yes, thank you, Chair, and thank you, Mark. It's really good to know about all of the work that is going on in very difficult circumstances. I just had a question about our link with Healthwatch Norfolk, because in the past we found them to be a very valuable source of research and feedback from patients and the population. I wondered whether you'd like to comment on that.
And before you respond, Mark, I think we do have Judith Bell on the call as well, who is representing Healthwatch, and if I don't know whether Judith also wants to comment on that as well, if she's able.
Yes, please can hear me. Yes, I'm very happy to. In the first wave of the pandemic, we worked quite closely with Norfolk County Council Resilience Recovery Cell, Community Cell, and we did a survey for 10 weeks, and we reported every 2 weeks, asking people how they were accessing information and health services and their experiences of that. Overwhelming kind of responses from that was mixed, really. People, depends what resources people have got in terms of help and support they can access themselves. But I guess key messages I would remind people of are that mental health services were often seen as not adequate for the need, and obviously the need has increased hugely because of the pandemic. There was a lack of information for people with sensory impairment, so people with visual loss or hearing loss were struggling to get hold of information. And the other final thing, and I know there's lots of work going on and we're about to be involved in another study in combination with Healthwatch England, is about digital exclusion, because obviously the pandemic has meant that advances have been incredible in terms of people accessing healthcare in different ways, either on the telephone or through video conferencing. But there's a lot of people not able to use that, don't have the facility, the skill or the equipment, and we have to ensure that those people aren't left behind. So I think that's a summary really of what we learned in the first survey we've done. We now have a second COVID survey running, which will run well, we haven't decided. It depends on how long the kind of current situation lasts for, but we aren't reporting every 2 weeks on that. We reserve judgment on how often we'll report. So, and that's only been running for 2 weeks, so I don't have anything to say on that at the moment, but they were the messages from the pandemic phase 1.
Oh, great. Thanks very much, Judith, and thanks for coming into the meeting. And I think your points about particularly about patients with mental health problems and lack of access to digital just highlights, I think, what Tracy was saying earlier about how important it is that when we develop services or we provide services, that we're mindful of those people who have difficulty with accesses. So addressing those inequalities of access is so important. I don't know, Mark, whether you want to come back on that, but yeah.
I did, yes, I could. Just in the brief time I've been involved since we started single CCG, it's been really apparent to me how valuable the work of Health Watch has become and what an important partner for the CCG it is, and I'm sure will continue to be as we look to promote engagement opportunities and commission work.
Okay, great, thanks. John, and then Claire, following that.
Thank you, Chair. Just briefly following on what Judith just said, I was made aware yesterday that we've been awarded a relatively small sum of money, but £10,000 for a specific project to support digital inclusion for those with hearing impairments, because that was one of the elements of feedback, I think, from an earlier report. So there's a piece of work that's about to kick off there.
Great, thank you. And Claire, did I see that you had your hand up?
Yes, thank you, Chair. Perhaps just to mention that I think one of the elements of the COVID Protect project that we were particularly proud of was having the virtual call handling team, or the call handling, non-clinical call handling team. So people who we felt were probably digitally disadvantaged, but who had that opportunity to access by telephone. And actually what we were able to demonstrate with the data was that actually we were able to increase engagement because there were a group of people who we could identify that needed to be contacted in that way. So that's something that we've been really keen and conscious to build, and all the subsequent projects around that. So albeit I completely accept it's a challenge in what is inevitably a digital world, and we can't be absolutely sure, and I don't think anyone could be, that we have captured absolutely everyone, but I think that just demonstrates how important to use old-fashioned methods, if you like, for want of a better term, remains. And also just to say, again, working with Health Watch, I'm in fact meeting with Health Watch myself on Monday to look at how they can support us more with some of our ongoing projects.
Great, thank you. Arden next, and then Tracy.
Thanks, Anu. I think it's a real shame actually that people's perception of mental health services is that it's not wide-reaching enough and available enough. I think some of that probably is around just lack of knowledge, and also that not being digitally enabled. For instance, since the start of lockdown, we've seen the first response service, COOTH, IAPT have expanded. Age Concern and Alzheimer's Society have all been engaged and involved, but I think it probably is a consequence of people just not having access to some of those digital platforms. And you know, the Mental Health Trust, of course, have been using Attend Anywhere as well. So the more work we can do in partnership to try to communicate more effectively about what is available, I think would be, from all systems partners, would be fantastic.
Great. Thank you. And Tracy?
Yeah, mine's a comment really, just something that I became aware of last week, that as a system, in respect of Respect, we have been nominated as a system, certainly the CCG, working with our colleagues for a national award, which I think is testimony to, you know, the kind of the rollout of that and the support with that in the system during a very, very difficult time. So I think that's worth acknowledging today.
Okay, thank you. Thanks very much for that. And so, are there any other comments on Mark's report, or any questions? No. Okay. Thank you, and thank you, Mark, for that report. Was there anything you wanted to finish on, or should we move on to the next item?
No.
Great. Okay. Well, item 10 then we'll move to, which is to approve some updated policies, threshold policies, which were sent to you. And I think Mark Lim is going to give us a summary of what you've been asked to approve.
Thank you very much, Chair. There are 4 policies here for ratification, which have previously been through the Clinical Policies Development Group. Essentially, the lipoma and the hypnotherapy policy is unchanged. In terms of the wide bore MRI, so for those less familiar with it, a wide bore MRI, costs quite considerably more than a normal MRI, by a factor of about 2 or 3, and we usually have to send these patients out of region for that. So because of that, we do have a policy as to which patients should have that. The previous policy was a bit confusing in terms of requirements for sedation and claustrophobia as a reason for potentially needing a wide bore MRI. So hopefully, as you can see from the comparison document, we've clarified that, ensured that patients aren't asked to go sedation if it's not clinically appropriate, and that side of it is recorded. And then finally, the benign skin lesions policy. So those previously on Joint Strategic Commissioning Committee will have seen a previous version which only applies to adults, and so we've updated the guidance and working with the consultants at each of the hospitals, and now contains sort of both adults and children. We've done quite significant reformatting of it because the previous policy was a mixture of things that aren't routinely funded, things where you need to try something else first, and things where not normally funded, but if you're worried about this, you need to refer. So hopefully by splitting it into the sections, you can see in the policy, hopefully that is clearer for potential referrers and also for consultants receiving these referrals. So very happy to take any questions on the policies. Thank you, Anu.
Okay, thank you, Mark. So this is an item where we're asked to approve policy. So initially, are there any questions of clarification that people want in terms of what you're being asked to approve? No, it's all self-explanatory, no technical issues or clinical issues for lay members? No, good. And are there any questions? No, okay, well, we're asked to, for assurance, as Mark has said, these policies have gone through a process of involvement through the Clinical Policies Development Group and have been to the clinical executive. So clinical members of the governing body have seen these documents as well. So we're asked to approve those 4 policies. Can I ask for your approval? Yeah, nodding will do because I can see you all. Yeah, I think that's unanimous. Thank you. Okay, well those are approved then. Thank you. And we'll move on to item 11, which Michael Dennis has joined us for. And this is to review and approve the recommendations from the Drug and Therapeutics Committee. So over to you, Michael.
Thanks, Chair. I'll take the papers as read. So these are the outputs from Norfolk and Waveney TAG Therapeutic Advisory Group that have been through a further process through D&T and briefly discussed at Clinical Executive Committee prior to coming here for sign off. And there's very little controversy about most of these. They're nice guidance or review of pathways or business cases from the local trusts, which, as I say, have been through local processes, and nothing particularly that causes any financial consequences. Just one thing to note is on the October paper, the draft guidance consultation on atrial fibrillation. The draft guidance was a little surprising and has created a little bit of controversy nationally. So as an organisation, we did a detailed response to the consultation, which went through our TAG colleagues, and a stroke physician at the NNN also commented on that document. So we'll wait and see what comes back when it's finalised. It's late February 2021. We'll see what NICE come back with as their final consultation response. But happy to take any questions.
Okay, thank you. So there are a few recommendations there. So any questions on any of those recommendations being put forward to you today? Yeah, Rob?
Yeah, thank you, Chair. It's probably more of a question for John, I think, but just looking at the column around recommendations for the future. I'd just like to hear whether John's building in the necessary financial provision into our future financial plans.
So happy to that. Michael and I have had a conversation offline about the issues that are flagged in the report today, and it doesn't appear to be anything of any particular financial significance that we would need to factor in. I think there is the risk factor that Michael's flagged in terms of new AF drugs, but the likelihood is that we wouldn't be implementing those anyway, is my understanding. So the cost pressure would be minimal. Is that anything that you would look to add?
No, I mean, if NICE do finalise their proposed guidance, I think we would. We've already had some discussions about it. We would recognise it as an interesting piece of guidance, but I think we would have to say that it's something we almost certainly won't be following to any extent because of the consequences, certainly financially and in terms of relevance to our patient group.
So I think that is I guess that is a risk then. So we ought to acknowledge and quantify that risk if that does get approved.
Yes, I did come up with a figure. It could cost us an additional £8 million a year if implemented.
Well,
yes.
Yeah. So John?
But I think what we're saying is that as and when that's approved through NICE, it would clearly come back here for recognition and for recognition approach that we would look to take to it. And at that stage, we would absolutely surface if there was anything like that cost pressure. But the expectation now is that that wouldn't be the case when it gets to that stage.
Okay, so it's a watching brief, and it'll come back to governing body if that does get approved by NICE, and we'll deal with it then. Okay. Any other questions on the recommendations that have been requested to be approved? No? Okay. So, I mean, I did, as I mentioned at the beginning, I have taken chair's action on a couple of the recommendations because of timeliness. But can I ask you to approve the remainder by a nod of heads? Yeah, okay, that's unanimous. Thank you. So we're on to item 12, which is the finance report. So John, our finance director, is going to present that.
Thank you, Chair. So just a very brief introduction, a reminder of the unusual financial regime that we've found ourselves in this year. So the first 6 months of the year, we had funding that was based really on what we spent last year, and then we applied retrospectively for top-up funding. The second 6 months of this year, that system's been changed. So funding has been distributed more to the NHS as system-wide envelopes that we then look to manage within, which has its own challenges, but it's better in terms of making the link between local decision-making and financial accountability. So that's the regime that we're in. The report that's in front of you covers two things. It covers the year-to-date financial position as at month 7, and it also then picks up the issue that was on the action log earlier about the approval, finally, of the financial plan for the second 6 months of this year. So just first of all, picking up the position to month 7, as the report shows, we're actually reporting an adverse variance of nearly £22 million after 7 months of the year. And that's in the context of a budget for that period of about £1 billion. So it's a couple of percent. This is a technicality, and it comes back to what I've just described in terms of the financial regime, whereby we incur spend, then we apply retrospectively for top-up funding. And the majority of that £22 million gap relates to top-up funding that we're still expecting for month 6. Because it was the last month of retrospective claims for top-ups, there's been a lot more scrutiny nationally of what organisations are putting through, CCGs and providers. So we're expecting to hear by the end of November that, the funding that we'll receive. So that's the majority of that. The other element that we're still allowed to claim from month 7 onwards is specifically COVID-related costs for the hospital discharge programme. So again, there's a chunk of that figure there that relates to a claim that we've put in for costs that we've incurred in October relating to discharging people from hospital. So it is a technicality. We're expecting to receive that funding, but clearly there's a risk to the CCG, however small that might be, until that funding is received. So that's the month 7 year-to-date position. And so the other part of the report really is talking about the financial plan for the second 6 months of the year, and that's section 6 of the report. So this has been an iterative planning process over several months now, focusing on system to start with, the Norfolk and Waveney healthcare system, and then the CCG as a part of that. So initially back in September time, when we put our estimates in as a system for what we thought our spend would be in this second 6 months of the year, we thought we could be in the region of £50 million adrift. There's been a lot of work done since then to clarify the guidance that's been out there and that has been emerging and evolving, to clarify our understanding of the particular financial envelopes that were attributed to systems, and to understand better our cost bases as organisations and challenge those and respond to challenge from the regional team. So we made our final submission, fingers crossed it's the final submission, a week or so ago, which showed a system deficit of £19 million, 19. And that's the CCG within that is the best part of £5 million. The rest of it relates to the providers within the Norfolk and Waveney system. We're still waiting for further confirmation of that position, and also confirmation that's the end of the planning process, and confirmation that effectively that's an allowed deficit. That's our expectation at the moment, that similarly to the normal annual financial planning process, some organisations are permitted to excuse me, make a deficit. And so therefore that's our expectation at this point in time. Certainly the initial response from the regional team has been appreciative of the efforts that we've made as a system in reducing what had previously been looking like a more significant gap, been appreciative of our efforts to reduce it to that level, and our expectation therefore is that will be signed off. In terms of that residual gap that we've got as a CCG, section 6 just talks a little bit about the reasons for that gap, and really it's things whereby we think the funding formula doesn't quite keep pace with the cost that we've got this year. So things like continuing healthcare, now that the hospital discharge programme for patients discharged in the first 6 months of the year, that bit has stopped, and those patients are meant to be being assessed for continuing healthcare. We are expecting to pick up therefore increased spend. There's also some pressures on prescribing that we're anticipating. So a few areas that are bubbling away that lead to the fact that we think we can have a gap of around £5 million. Final comment is that this position has been discussed at the Finance Committee, both the year-to-date position at month 7 and the plan process for the second 6 months of the year. We've kept the Finance Committee informed over previous iterations. And we are asking the governing body to approve that plan position for the second 6 months of the year at a deficit of £4.9 million. So I'll stop there, and I'm very happy to take questions on any part of the report.
Okay, thank you for that. Any questions, particularly Hein, was there, as chair of the Finance Committee, was there anything you wanted to add to John's report?
Thank you, Chair. My name is Hein, I'm a lay member for Financial Reform. I don't have much to add to John's story, just to let colleagues in the governing body know we did spend some time in the Finance Committee seeking assurance on the confidence level behind that gap that John described of nearly 5 million, and John and his colleagues were able to provide comfort due to the number of iterations and clarifications on the robustness behind the assumptions that led from the initial gap position to the current position. So in that sense, I'm comfortable and happy to support from where I sit. Thank you, Chair.
Okay, thank you. So any questions or comments on John's report on month 7 and the plans for the remainder of the year? Yeah, Rob.
Yes, thank you, Chair. My sound quality is drifting in and out, so forgive me if I've missed something that's been said. I think I heard John say that the top-up funding, there is a risk attached to receiving that full amount, but we should know, John, relatively soon as to whether we will be receiving that.
Yes, indeed. So 30th of November is the date by which we've been told we will receive confirmation, and there's a regular backwards and forwards of queries actually as the national team is asking the regional team to ask us to clarify some of the issues that we've claimed for. So that was still going on this morning. So 30th of November we will know.
Good, and it was helpful to hear Hein talk about the Finance Committee's review of the submission bridge items that are set out on page 9 in John's paper. I was just thinking, John, for future reports, it might be helpful to show in another column whether that's money that we'll definitely receive or whether it's money that we're still waiting to hear, so that we can gauge how much we've got in the bank and how much is still to be notified of.
Very happy to do that, Rob. Yeah, thank you.
Thank you.
I think you're on mute, Anut.
Yeah, I am. Yes, I am. Mark Jeffries, did you want to make a comment? I think I saw your hand.
I did, yes, thank you. The COVID, you have any idea how our expenditure compares with other CCG been done, whether we're above average or below average?
We haven't benchmarked CCG specifically, but we have benchmarked other systems in the east of England. And in that benchmarking, we've certainly not been the lowest in terms of the gap. Some systems have apparently not had a gap between their expected spend and the envelopes that were notified, but we're not the highest either. So we're probably in the upper half, but not an outrunner. But as I say, that system as a whole, we haven't got any benchmarking in terms of CCGs and this particular financial framework, because it will be so difficult to gather that information. It's not really publicly available, and it will be down to how systems have utilised some of the funding that's available for their discretion as well.
Thank you.
Okay. Any other questions or comments? No. Okay. Well, we've had the month 7 position reported, and we're asked to approve the remainder of the 2021 6 months and month 7 to 12 plan. So can I ask for your approval for the plan as presented to you? Yeah. Okay. Thank you. That's approved. So let's move to item 13, which is to review the governing body's assurance framework for the CCG, setting out the current risks to the organisation. Karen, did you want to talk us through?
Yes, Chair, many thanks. I am going to take the paper as read. What we have done with the paper this time is had a look again at the risks that we highlighted to the governing body last time, and just ensured that these were covered throughout the board papers. So today we will have discussed the vast majority of those risks that were set out in the GBAF. There are just 2 that were missed off, and one has been dealt with in a development session, you'll all be aware, in August around workforce, and another will come to a future meeting that's around CHC, which is they're working very hard with that at the moment. So the risks are here and highlighted again, and we're happy to take questions. Thank you.
Okay, thank you. So any questions for Kath on that? No. Okay, thank you. So we'll note that review. So item 14 is to review the annual core standard submission from the CCG and how we plan for emergency situations and around. And Kath, you're going to talk us through that.
Yes, I will. Thank you, Chair. So I will aim to be very brief, and we'll look to call upon Karen for if there are any detailed questions. So in essence, we are required to assure ourselves of our readiness of our own organisation, but be aware of the readiness of the wider NHS provision within Norfolk and Waveney. We do note, of course, that we plan every year for incidents such as COVID, which we are experiencing, and that has actually provided a robust test of our readiness within our system. And it was recognised that if we were to do further testing of our assurance processes, that may not necessarily be appropriate when we're preparing for the resurgence of COVID this winter. So section 1 of the paper sets out the activities, the responses and areas of priority, including, for example, training of our on-call staff, exercises that had been undertaken, and section 2 sets out the annual assurance process and the planning for 2021. And also within section 1 and the appendices, the governing body presented with the assurance ratings from the CCGs, both the 5 CCGs prior to the 1st of April, and of course, going forward, collating that into a single approach. So we are assured of our CCG readiness and note our provider colleagues' position in relation to this. I'm happy for Karen to take any questions, if that's okay, Chair.
Okay, thanks very much. And I mean, when I read that, I did think actually we've had a pretty good test of our emergency preparedness this year, haven't we? Are there any questions or comments on that annual process and review of that preparedness? No? Okay, so we're asked to note that. Thank you. So item 15 is. I think somebody's got their. Kathy, I think that might be yourself. Somebody's got their microphone on. That's better. Thank you. So item 15 is to update us on progress for external auditor procurement. So John, do you want to talk us through that and what we're asked to approve today?
Yeah, thank you. Hopefully the paper's self-explanatory. Just a couple of words by introduction. It's clearly mandatory for all organisations to have an external auditor. Our previous external audit came to the end of their contract, so the governing body approved in September that we would go out to procurement. We've since been through the relevant bits of process. We've established an external auditor panel chaired by Rob with members of the audit committee as members. And part of the paper today is to ask for formal approval to the terms of reference for that external auditor panel. Apart from that, the paper is updating on progress, and because of the timings where we're just in the process now of concluding this process, but obviously it wasn't in time for this meeting today, and we need to appoint before the end of December, so we can't wait for the next public meeting of the governing body. So we're asking for governing body to give approval to Anupa's chair to be able to approve the recommendation of the external auditor panel. So they're the two key things really to flag for today. I think I would just comment as well that we had a meeting this morning of the auditor panel, recognised the position with the process that we're in, and it could be that we may be able to actually respond to this quite quickly now. It may be that we don't need to go through the presentation process, which was identified in the paper, and may be able to just save a couple of weeks effectively in terms of the decision process and then move through to mobilisation. So it might be sooner rather than later. The two key things today are for approval of the terms of reference of the auditor panel and to delegate authority to Anupa's chair. I don't know if there's anything you wanted to add as chair of the panel.
No, thank you, John. You've covered everything admirably. Thank you.
Okay, thank you, John. So you've got the update on the process, the terms of reference for the auditor panel. Have you got any questions or comments on those two items, first of all? No? And finally, you're asked to approve the terms of reference and to delegate authority to me as chair of the governing body to approve the contract, as we need to make a decision before the end of this month, I think John said. So can I ask for your approval? Yeah, okay, thank you. So we now come to the section which is updates from the committees of the CCG. So first we'll take a report from the Quality and Performance Committee, which Kathy, you chair.
Thanks, Chair. I'll take the report as read. This is a report of the October meeting of the Quality and Performance Committee. I just want to draw your attention to one thing. At every meeting, we endeavour to take an in-depth review of a service pathway that features on the Quality and Performance Committee. Risk register, sorry. And at this meeting, we focused upon eating disorder services. And the key points I wanted to draw out for you was that we thought that we have to see this pathway in terms of an all-age pathway so that we can understand how people flow across the pathway. Secondly, that during the period of the pandemic, we've seen a rise in both the prevalence and the acuity of cases of eating disorders and disordered eating. A range of innovative new approaches are being implemented across the system and lots of transformation is taking place, which is really positive. But we also recognise that important learning will emerge from this transformation, but also from the recent coroner's case. So we are going to keep a watching brief on this pathway because we recognise that it's important for future discussion. So apart from that, I'm happy to take any questions at all about the report.
Thank you very much, Kathy. Any questions for Kathy on that report? No? Okay, thank you. So we'll take the report from Rob Bennett from the Audit Committee.
Okay, thank you, Chair. Again, I'll take the paper as read. It's a short report of the meeting that we had in October. Two particular points to draw to your attention. Firstly, in section 7, we are doing some work around the review of the status of our policies across the CCG, and that work is ongoing. And then finally, in section 9, we had a very helpful update on information governance from the team, and that links very neatly to the cybersecurity training that we had as governing body members in October. But again, I'm very happy to take any questions.
Okay, any questions for Rob? No, okay, thank you. Item 18, the Finance Committee, which is chaired by Hein.
Thank you, Chair. Also, I will take the paper as read. It concerns October. I have one addition to make. There is a brief paragraph on the CCG merger benefits regularization. It's just to remind that there will be an independent review by internal audit on the CCG merger benefit realization. So that will come back at the requisite time. John Ingham earlier provided an update on what the main ingredients of the recent discussion in the Finance Committee was. I'll add one item is that we agreed months ahead to spend good time towards what the finance plan for next year will look like. As John has explained, this year was not a normal regime, and it's appropriate we take enough time and look ahead at how it will shape up. Happy to take any questions there.
Thank you. Hein, any questions for Hein? Okay, so we'll take the report from Doris Jamieson, Chair of the Primary Care Commissioning Committee. Doris.
The report is for October and November, and I take, if there are any questions from anybody. We've made a decision that, given the amount of work that officers and the CCG having to undertake, we are going to try and keep what is coming to the Primary Care Commissioning Committee to what we really need to do, so to release officers time to cope with the current stresses that they are under.
That's very sensible. Thank you, Doris. Any questions for Doris and the work of the Primary Care Committee? Okay, thank you. Item 20 is an update for the governing body on the work of the Conflicts and Interest Committee, which Rob, you chair.
Thank you again, Chair. This is a summary of the discussion that we had at our first meeting in September. Again, I'll take it as read, and I'm happy to answer any questions. Just one point that I'd like to draw your attention to, and that is in section 3, the mandatory training. We've got good levels of compliance with the training requirements, but it is an area that we are going to keep under review. And anybody that hasn't done the training will be reminded of the need to do it.
Okay, thank you for that. Yeah, so just a reminder, if you haven't done it, we won't name and shame, but we'll be following up on that. Thank you. Rob, any questions for Rob? No. Thank you. So we're coming towards the end. So we've got item 21, which is questions from the public. And I mentioned at the beginning of the meeting the process for doing that. And Karen, I think we have had some questions from the public, which we're going to put on the screen. And yeah, do you want to talk us through?
So we have received some 5 queries from the public in advance of the meeting. Some we have been able to answer because they came in a while before the meeting, and we will just flick through these slides now so that people can have a look back at it on the YouTube. We'll also circulate these to board after. There are a few queries that we have not yet had the time to answer in advance of the meeting because they only came in a few days ago. Again, all questions that are received from the public for the governing body are put on the website along with the answer. We also send the answer directly to the person that asked the question. I can also confirm today that we haven't received any questions as the meeting has been ongoing, so I don't have any of those to go through. So perhaps, Ian, we could just slowly go through the questions through the slide deck. And as I said, they'll be circulated after, and they are also available on the website after as well. If you just scroll through, Ian. The next one. 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 I think that's the end if you just... Thank you. So people are able to review those again on the recording, and we will circulate them to the board as well.
Okay, thanks very much, Karen. So you will have access to those. Obviously, we did go through those relatively quickly, but if you want to make comments, then you can do so. Are there any immediate questions or comments on that, on the questions from the members of the public? Yep, Melanie?
Anoop, just seeing these for the first time, I just wonder, as we do have, we are ahead of time in the meeting, I wonder whether it's worth just going through those again and just reading out the question and the answer so that people can indeed just comment on them and understand it. And I think there's a question as well about, I didn't immediately understand what query 1 was stating as well, and John has comment about that. So I wonder if we could just go through them again a little bit more slowly, if that's all right.
Yeah, I think that's a good point, actually, because I'd seen them before, but actually they do take a bit of time to process, don't they? So we, as you say, we have got some time. Before we do that, Hilary, were you wanting to come in on that as well? I saw your hand up.
Yeah, just a similar question, really. Would it be possible to have them in advance of the meeting next time? Because I was trying to speed read them, but I'm not that quick. So it'd be really helpful to have the opportunity to read through them before we meet next time, if that's possible.
I think that's a good idea. Yeah.
We are doing these, they are coming in thick and fast from when the papers come up. So we may just have to have a cut-off in time, and you will get what we get up to a certain date. And then you'll have to have the others after. There were, I think, at least 3 that came in the last day, so we wouldn't have been able to get those forward to you.
But I think, as Melanie's saying, it is important when we've met in public normally, there is an opportunity then for the governing body to consider the questions that have been asked. So we want to kind of get as much engagement as we can from the governing body involvement as is practicable with the way that we're working. So question 1, is this related to the Freestyle Libre? Is this a question around that? Because it wasn't entirely.
That's what the question, the response indicated, that it related to flash glucose monitoring.
Yeah. And so, because the answer was very much focused on that, wasn't it, on the flash glucose monitoring? Yeah.
I'm happy just to make a comment in that regard, Chair.
Yeah.
Some of the discrepancy relates to the time lag between when items are authorised or prescribed as to when the data is collected. And I think also some of the interpretation of the data may have related to the 5 previous CCG areas rather than collectively as one CCG area. So as a system, we now exceed the 20% threshold, which is what the expected threshold is. There was at one stage slight variation across the patch, which is perhaps predictable given the distribution of population. But we are now above the 20% and have been for slightly longer than various media chats have suggested.
Okay, great. Thanks for that update on that. Thank you. So shall we move on to the next question? So this is related to the PRISM model for mental health services.
So, Chair, the response here was sort of building on the questioner's point about the PRISM model, which originated in Cambridgeshire, and a response about how we've developed the mental health offer within our primary care networks. So that was the basis of the answer to the first point, just a progress report really in answer to that question. The second question was actually unrelated and just was regarding the ability to make questions or to ask questions during the public meeting. And the response to that is a position that's still under review. So that just summarises the 2 points in that second one.
So the answer is that the model has been adopted by the whole CCG. Yeah.
Correct. Yeah, this is the primary care network mental health offer, Chair. Yes.
Yeah, and if I can just come in on the second part of the question, which was about the opportunity for members of the public to ask questions during the meeting. If we were in a room, which hopefully we will be once again all together, if we were in a room, we don't usually accept questions from members of the public, given that this is a meeting of the governing body held in public during the meeting, unless there is an exceptional agenda item, which I know that sort of thing has happened before, but really by exception. I think that the same would apply the same does apply in a virtual meeting. Just is very difficult with the running order of the meeting, and for members of the governing body to focus with questions coming in during the meeting. However, there is an opportunity to ask questions at the end, and I think a further development today, which is really good to get feedback on from members of the public, that there is the opportunity to ask questions as the meeting goes on and email them, if people have the technology, to an inbox that is monitored throughout the course of the governing body meeting, so that we can share those questions that have come in, and if we can respond to them at the time, we will, and if not, we'll take them away. I think that remains the position, which is a common position across public sector meetings held in public.
Okay, that's really helpful, Melanie. I think following on from Hillary's point as well, that if we do have questions before the meeting, if we could circulate them to governing body members so that they can kind of process the questions and maybe kind of come to them within the meeting in terms of their responses. And I think if there are particular questions which are really important, then we should look at those questions beforehand and maybe try and get some sort of interaction with the person that's asking the question if we can. Maybe as you say, through email response during the meeting. But let's be open about how we approach questions going forward, because I think for the next, I would think, at least 6 months, we're going to be likely to be working in a similar way to which we are now, and we do need to adapt if we need to how we respond to questions. Thank you. Let's move on to the next. Yeah. So this is in relation to inpatient services for patients suffering from anorexia and the high mortality rates associated with it. And I think we're aware of some of the concern around the tragedy that occurred a few years ago in Norfolk. And
yes, Chair, we've responded to that. I think you can see the response up now, but just a few key issues that we pointed out, and as the questioner rightly points out, there are a range of areas that we will be required to look again at as a result of the coroner's statement on that recent case. Not least improvements to medical monitoring and the fact that we don't have a full locally commissioned service across Norfolk and Waveney at the moment. But we do have a plan to address that, and actually Arden has been doing some great work with local clinicians to think about how we advance that piece of work. We've also looked at opportunities for improvement in terms of what is termed marzipan guidance. That's the management of really sick people with anorexia nervosa, and our plans in relation to that. Also pointing out, as I did to the coroner actually, recent investment we've made in a model called the Freed model, which is around early intervention and support for people suffering eating disorders, and it's based on a successful model that is in operation in the South London and Maudsley Foundation Trust. And finally points to some of the developments that are emerging around the provider collaborative and new care models. So it's a reasonably comprehensive response there, Chair, but it's not the end of that response. Clearly following the inquest, there will be other things we need to address as part of our commissioning going forward, but that's featuring as part of our work plan for future months.
Okay, great. Thanks for that, John. Was there another question, or was that the last one? No.
Final two questions have not been responded to yet, so we're working on those, but the answers will be available, said, on the website, and they'll be responded to directly as well. Yeah, so one around ADHD assessments and the concern around weights and referrals, and the next one was around eligibility for continuing healthcare funding. Okay, so we will those weren't on the agenda, but we will address those. Yeah. Okay, thank you. And yeah, thanks, Melanie, for asking us to spend some more time on that, because as you say, we were ahead of time, and I think that was time well spent to look at that. So we've reached the end of the agenda. Is there any other business? Yeah, Rob.
Yes, thank you, Chair. Just wanted to say that I tuned into the staff briefing yesterday afternoon, which was led by Mark, and I found it really, really valuable. And I think it's an excellent way of keeping in touch with our people, where people are working remotely and have been working remotely for a long time now. I also just wanted to mention that it was very useful to have Doris on the call as well, introducing her role as the Speaking Up Guardian, because again, we know that's a very important part of what we do. So giving that role, that profile yesterday, I thought was a very good thing to do.
Oh, thank you for that update, and thanks, Mark and Doris, for that. Which Mark, by the way?
Sorry, Mark Burgess.
Right. Okay. Just
And his dog, by the way.
Thank you. That's great. Well, look, thanks very much. If there's no other business, then we'll. Oh, there is Doris.
Rob has prompted me. Actually, it's I was asked to trail some training for people to speak up. The first module is now online. It's been developed by the National Guardian Office. And we are encouraging everybody to do it. It took me about 10 minutes. I think if you were doing it really properly, probably take 15, 20 minutes, because there was some free text box that I didn't fill in because I didn't think it was appropriate for me to fill in. So I would recommend governing body members to log on to your ESR account. You have to search for the training because it's not mandatory at the moment, so it won't show up in your record. But it's actually very user-friendly, and you don't get tested at the end, which is really good. And there's going to be a level 2 and level 3 module going to be introduced as well, which again will be encouraging managers and governing body members to undertake in the future.
Okay, no, thanks very much. So make sure you're up to date with your mandatory training, but also that doesn't mean that you shouldn't sort of make use of other good training that's available like this. Thank you. Hilary, did I see your hand up there or not? No? Okay. Well, if there's no other business, we'll close the meeting.